Thank you for joining us for this short video on choosing wisely, working with diverse communities to support appropriate care during a pandemic, which is part of our Choosing Wisely during COVID-19 conversation. I'm Kate Carmody, and I'm the Program Associate for Choosing Wisely at the ABIM Foundation. We hope you are well and that you and your families are safe. Today's video features a conversation between Dr. Lisa Letourneau, Choosing Wisely physician consultant, and physician assistant and professor Carl Toney. We are excited to welcome Professor Toney to the Learning Network. He brings a wealth of experience as a physician assistant in medicine and a leader in academia and public health. He has practiced clinically in family medicine, internal medicine, and geriatrics, and has served academically on the faculties of Duke, Emory, and the University of New England. He currently serves as a healthcare planning consultant. Kelly Rand, Program Officer for Choosing Wisely, will start with providing some context on the disproportionate impact COVID-19 has had on communities of color and the structural aspects of our healthcare system which exacerbate that effect. Our conversation will focus on ways to mitigate those structural barriers and communicate about needed care and prevention. Over to you, Kelly.
Thank you, Kate. So before we launch into the conversation, which is really the most important part of this video, I just wanted to set a little bit of context to talk about why this is such an important conversation to have. COVID-19 has been a pandemic that's affected the entire country and the entire world, but it hasn't necessarily impacted everyone the same. So one of the things that has really risen to the top in the last few months is that both cases and deaths by COVID-19 have disproportionately affected people of color, in particular African Americans. This chart shows you how many more African Americans have gotten COVID-19 and how in many cases those cases progress to either serious illness, which we don't know what the long-term ramifications will be, or in many cases more serious impacts like death. Again, another chart that shares that this disparities in people of color is also affecting our Latino population. And many people have tried to understand why people of color are being disproportionately affected. And much of it has to do with structural elements that are part of our healthcare system. Because of lack of access to care and lack of trust in care, many people of color have a higher prevalence of cardiometabolic diseases, which lead to worse outcomes in COVID-19. Much of this is because of historic segregation, which has caused poor environments for people to be raised in our unfortunate income and wealth equality, where many people of color have not seen the wealth gap change from the 1950s, a higher rate of people of color in incarcerated groups and in homeless groups where it's much harder to prevent COVID-19, an underrepresentation in physicians, physician assistants, nurse practitioners, which really impacts, again, access to care and communication of care. And a higher representation in communities of color in essential worker jobs where people really have to make the decision on whether they are able to pay their rent or whether they're going to be exposed to this disease, which could be potentially very catastrophic for them. And as we know in our healthcare system, even when there aren't access issue, many people of color don't necessarily receive the same level of care. So within Choosing Wisely and high value care research, we've found that in many situations, there's what some researchers call a double jeopardy, where patients of color go in and they may have a higher risk for low quality care and a higher risk of not getting high value care. So we don't know exactly how that plays out in the COVID-19 epidemic, but it would be reasonable to assume that these whatever structural implications cause this to happen in regular care probably translate into COVID care as well. And another issue that we think is probably important about communication is there is a very valid historic distrust of the healthcare system that stems back from historical issues like Tuskegee and goes up to present day access issues and care issues where if people of color go in to get care, they are more likely to get less valuable care and less valuable care. So this also translates into how will we deal with COVID once we do have a vaccine. A recent survey suggests that very few people think that they would trust a vaccine even if it comes out. So there's many issues to talk about in how to translate about prevention of COVID-19, how to help populations of care seek the care they need, how to help them advocate for the care that they should be getting, and what we need to do as a healthcare system to make a vaccine possibly viable. I think we're mostly going to let Professor Toney and Dr. Letourneau discuss what might work. But one thing that has come out in the literature that has some valid points to it is using community health workers. There are many ways that community health workers can be a trusting bridge from the healthcare systems to communities. And they have usually many skills which can be helpful that the healthcare community doesn't have, such as more members who are bilingual or multilingual that can help interpret and talk to people in the language that they need to speak in. Having relationships with organizations that work on things like social determinants of health, like food pantries and local agencies providing assistance with benefits. And they're also many times able to help navigate insurance issues or Medicaid issues and help people not only get care, but not be left financially devastated by getting that care. And now I'm going to turn it over to Dr. Letourneau and Professor Toney to talk about some of the things that might be working in communities now.
Great. Well, thanks so much, Kelly, and thanks everybody for joining, and thanks very much, Carl, for being part of this conversation. So, as you've pointed out, Kelly, there are clear issues of trust here, and I just wanted to reflect that the Choosing Wisely program is really built on trust. It's built on trying to promote trust between patients and clinicians to try to make that distinction between high value and low value care. At the same time, we know that there are disparities in care related to a lack of historic and, again, very well understood, or excuse me, very understandable, not necessarily well understood, understandable lack of trust, particularly from communities of color and the US healthcare system. And now we find ourselves in a pandemic where we've got a whole new set of challenges about trying to convince people about the need to get high value care that's been postponed, whether it's preventive care or chronic illness care. So thinking about that, Carl, and particularly the current context that we find ourselves in, what advice do you have for providers on ways to build trust to get people to help people understand about the need to get high value care, and particularly when serving people from racially or ethnically diverse populations?
Well, first of all, it's a pleasure to be here, and I really appreciate the opportunity to have a discussion about this. In response to your question, I think the issue of trust comes from the ability to establish relationships. And one of the things that I have tried to use in my own practice, and certainly teaching medical providers and working with healthcare systems, is to have providers approach this from a given perspective that's based, I think, on one premise and one fundamental question. The premise is basically, and this is universal, that you can't help the patient if you don't know the person. So part of the problems that we have within our healthcare system on a day-to-day normal basis is the fact that we are in a situation now where we so rarely know the people that we are involved in taking care of. That kind of situation is only exacerbated when you begin to move outside of your cultural norms, which leads me to the question that I encourage providers to ask themselves as they start down this road. And that question is, how can I help someone? How can I be of service to someone who has a different worldview and also maybe a different set of health beliefs than my own? And I encourage people to consciously ask that question, because I think it puts them on a pathway that I describe as a road toward bidirectional acculturation, which very simply means it forces us as part of the system, as healthcare providers, not to stay static with the expectation that the patient will come to us and learn our system while we have no requirement or obligation to learn who they are and what their culture and their norms are. And that is, I think, the ability to do that and to engage your patient and understand who they are and what is the world they come out of is key and initial, as an initial piece to establishing a relationship, which will then provide you the building blocks to begin to establish trust. So that's where I start with my own practice, and that's where I encourage other folks to start as well.
Great, thank you. So from that context, and then thinking about this particular pandemic, right, with COVID, it's scary. It's just scary, right? People are afraid they're going to get it from touching things, breathing air, being in contact with folks, and that is all true. So recognizing that it's a scary time out there, do you think that the pandemic is creating even greater challenges in trying to establish that trust and get people to engage in needed care? And what do you think, in addition to those great suggestions you just gave about creating relationship as a way to build trust, anything specific that you think of in the context of this pandemic, as we're all wearing masks, you can't even see people's faces, right? So any specific recommendations around how we do that during these scary times?
Well, again, going back to what we saw on the slides, we are aware of the fact that a lot of people within communities of color and other minority groups often don't have access to sustainable care that provides continuity. So they're often engaging care in a very episodic way, and again, with people who are essentially strangers that they don't know. When you then add on the urgency and the terror, if that's not too strong a word, of something like this pandemic, individuals, it pushes, I believe it pushes people within the communities into two unfortunate situations. One, they don't understand what's going on, and they are looking for information and looking for help, but not sure how to come and obtain that help. And they often feel that they're not getting good information that's directed specifically toward them from a system that they don't understand often, and by people that they don't know. So they're caught in this two-way push-pull of needing the information and needing help, not being clear how to even go about to get it, and not having individuals that they feel they can trust to provide that information. So part of what we need to be doing, and everywhere in this country, is to be much more assertive and aggressive about getting out into the communities. Not, again, not waiting for the communities to come to us, but to get out into the communities with the information, with figures of two levels of authority, if you will. One, first and foremost, as your slides indicated, utilizing people such as the community health workers, which are really trusted individuals within many, many, if not most communities. They understand the communities, they're from those communities, they speak the languages, they understand the issues. So having those people there and being advocates for the community members, as well as being educators of the community, is critical. But at the same time, there also needs to be formal representatives from the healthcare system, from the medical community, authority figures who can be there with the community health workers to help answer questions and help the community members see that the healthcare system really is paying attention to their particular needs. And this is a particular issue when you're dealing with international communities, immigrants and refugees, who often view authority figures in a much more traditional way and a much more formal way than we have come to in this country. So having a doctor or having a nurse practitioner or having someone like that who is of that ilk, who is there physically, either literally in the community or virtually, at the same time the community health worker is there, provides that kind of approach that will provide people information and, again, help them with the trust. When we add on all of the issues that these people are going through in terms of all the political situations, the idea of coming forward and being perfectly candid about who they are, where they're from, having to wear masks, doing things that are just totally outside their norm, is incredibly frightening. And we hear all the time the fear that the communities have and the sense of isolation and fearing that if the virus doesn't get them, the government's going to get them in a different way. So it's a very complex situation, but we've got to put ourselves forward and engage the community where they are located.
Great, thank you. So I'm going to step back a little bit to the individual provider level and then kind of go back to some of the bigger policy issues. But you've been involved in teaching medical students, PA students for years now, and I suspect have learned a lot in the process of teaching. I also think that many of us are out there trying to do the best we can, but we all make mistakes sometimes. So between your teaching experience and seeing people trying to work hard in situations, but not necessarily always doing the right thing, what are some of the most common mistakes you've seen people make in providing care during challenging times, in trying to engage particularly disparate communities that you've seen and learned from your teaching experience?
Mm-hmm. Well, again, the pandemic merely adds on to the baseline of the challenges dealing with communities of color, both domestic African Americans as well as international communities. And we get into trouble as providers, I believe, and I try to share this with my students and the residents and other folks that I currently work with, because we don't understand and accept the fact that we have to shift the model of our engagement when we're dealing with people from other cultures, cultures that we're not familiar with. And by shifting, what I mean is we have to be willing and able to go back to the kinds of communication skills and interpersonal skills that we learned in medical school and PA school, in terms of active listening, in terms of how to have a dialogue with someone, meeting them at whatever level that they are at, in terms of recognizing that it is going to take a bit more time to engage someone from a different culture than it is to just do a 7.5-minute visit for a very simple problem. The communication and intercultural exchanges make the process longer and more complex. And that becomes even more so if you are also incorporating interpreters in because of language difficulties. So you have to therefore also learn how to effectively and appropriately utilize interpreters, which many of us, many providers don't have the opportunity to learn how to do. The other thing is, and it goes back again to understanding who the person is, we don't take time to find out anything about the culture of where this person's coming from. So we see this individual for a particular problem, whether it's related to the pandemic or some other problem they have, and we end up dealing with the problem and not with the person, and not with taking time to understand how is the best way to engage and get information from and information to this person. So it takes the issue of time, it takes reorienting how you process information in and how you give information back. When dealing also with people from other cultures, from other countries, we are still lagging behind in our utilization of cultural brokers who can help train the providers both beforehand, during the encounters, and often afterwards to how best to make the information appropriate and get the care to the person that they need. So the things that we're making mistakes on are the things that we're not attending to and recognizing that we cannot fit these communities into the traditional encounter box that we have established for the delivery of care. And again, when you add on the myriad of questions and concerns about the pandemic, it becomes even harder. So, for example, if you don't query about what the issues are relative to the social determinants of health that these people are, that your patient is facing, then telling them that they're positive and they have to go home and quarantine, what does that mean and how do they survive? And that's a question that faces everyone, regardless of their culture or race or background. But for people who don't really understand our system of both care and our economic system and our political system, sending someone off with that information actually makes it worse for them than better. So we have to be able to shift the paradigm that we're using and how we engage the patients. When we don't do that, that's when we get into trouble.
Great, thanks. So the old, well, I do the same thing for everybody. There's not a problem. I do the same thing for everybody is exactly the wrong answer. In other words, it can't be the same thing for everyone. Okay, and then now shifting a little bit from the individual effort, we know in most public health issues, right, health and public health, that real change happens with policy and institutional change. So thinking that our listeners are providers in larger systems, are there 2 or 3 sort of policy or structural changes that you would recommend that we get behind? You know, what are some key policy changes that you think we as providers need to be advocating for in our organizations to really get at some of these issues? Whether we know we can't do everything overnight, but are there some key ones that you'd really recommend that people be aware of and consider leading in their organizations?
Mm-hmm. Well, I think there are definitely some things that we can look at as it relates to what I would say is resource and knowledge. From a resource perspective, I think we need to be putting in at the local level, at the state level, at the service delivery institutional level, resources and a commitment to develop a much larger cadre of community health workers, interpreters, and cultural brokers, because these are the people that are going to be the mainstay, the glue, if you will, to connect the communities with the healthcare delivery system. And I believe those people are important, whether you're talking about immigrants or refugees, or whether you're talking about the indigenous, if you will, African-American community or Latino community. All these communities have different configurations and norms that the medical system doesn't understand. And we need to be able to have resources to address those in a sustained way. So that's number one. Number two is, I think as it relates to healthcare delivery systems, one of the things that I think would be very helpful is if institutions, hospitals particularly, but certainly even community-based institutions, instituted what I would call cultural grand rounds, which would be ongoing sessions to train their providers, both providers in training, house staff, residents, et cetera, as well as their practitioner staff, on understanding what some of the issues are and what some of the norms are that people are bringing to relate to the healthcare system. And then one of the other, I would say my last recommendation, again from a service delivery perspective, is you have to get out of the institution, out from behind the walls, and you have to have a formal program that brings the healthcare delivery services and system, whether it's from the hospital or community health centers, et cetera, into the community and spend time in those communities, being involved in those communities, not only when there's an emergent problem like such as we have now, but in an ongoing way so that you are seen as part of that community. And people recognize your investment. And that will again come around to the issue of trust in terms of information, and trust when it gets down to things such as we're about to face, and as we saw from the slide, in terms of whether people are going to be willing to take a vaccine that might help them, but they fear the vaccine because they don't trust the system from which that vaccine comes from. If you are a part of that community by being present there in an episodic, ongoing way, then that trust will be present as well. If I may tell you just one very quick story to illustrate what I'm talking about. Many years ago, here at Maine Medical Center, when they were beginning the first iteration of the International Medical Clinic, they were having a lot of trouble getting people from the various immigrant communities, refugee communities, to come to the hospital because it was not a system that they understood, and it was not a place they felt comfortable. So as part of trying to turn that situation around, the physician who was the medical director of the International Medical Clinic decided that it would be helpful if he went to the communities and just literally walked the streets and talked to people and met people so that he could understand their situation and their living reality, and so that they would be able also to see that someone cared. And so he did that, and he walked the streets. And within a short amount of time in a number of communities, because people literally recognized him, and the word went out that he was there in the community walking around, he then got to talk to a lot more people. He got invited into people's homes, and the word went out through both the formal channels within the community, but even the more important informal channels within the community, that there were doctors at the hospital who cared, and who cared enough to come. And that began to turn around the trust and relationship between the communities and the International Medical Clinic. A small victory, but a victory nonetheless, lessons that we've unlearned and lost over time.
Great, thank you so much. Well, that was fantastic, Carl. And I think, we can summarize it by saying trust, curiosity, and, making ourselves authentically there, right, for others in the community, and really needing to listen first as a way to that critical step of building trust. So thank you so much. That was incredibly valuable. I think we're pretty much at the end of our time. Kate or Kelly?
Yep. Thank you all for joining us. We hope this discussion has contributed to your thinking about choosing wisely during COVID-19. Please join us next month as we resume our live webinar series and discuss our newest technical assistance package, Focus on Patient Engagement and High Value Care. Thank you.